Hello everyone, welcome to Patho Excellence. Many students look at a skin biopsy and immediately think, what is the diagnosis? But in dermatopathology, diagnosis does not come first. Skin biopsies are small, fragmented, and often show overlapping features. So, if you do not understand the exact definitions of microscopic terms like spongiosis, acantholysis, interface dermatitis, or psoriasiform hypoplasia, you cannot correctly describe what you see. So, dermatopathology is a subject of definitions, patterns, and precise language. So, once your definitions are clear, microscopy becomes logical, viva answers become confident, and diagnosis becomes accurate. So, in this video, uh, we will understand why learning dermatopathology definitions is essential before making any diagnosis. So, in this skin biopsy interpretation series, today we are going to discuss dermatopathology definitions. Now, let's see what exactly the classification of skin disease, which is Whedon pattern based. Skin disease includes inflammatory dermatosis, epidermal differentiation, infections, pigmentary disorders, disorders of dermis and subcutis, appendageal disorders, and tumors, and some genetic and development disorders. So, this list is vast, and if you want to remember some common diagnosis, you must learn some important definitions. Another important thing, skin lesions are having some long names which are not even we cannot memorize if we don't know what exactly the skin disease name is. So, like for example, pityriasis lichenoides varioliformis acuta. So, it is abbreviated form is PLEVA. So, what it indicates? So, the pityriasis means scale. So, scaly lichenoid means lichen planus like. Varioliformis means healing and depressed scar with acute manifestation. So, if you identify microscopically this type of uh, features, then you can diagnose this type of lesion. Second is like pityriasis lichenoides chronica. So, pityriasis, now you know it is scaly. So, in microscopy you have to identify scaly or that type of differentiating features. Lichen planus like lichenoids, and chronica means chronic disease. Now, keratosis follicularis. So, it is keratotic lesions of follicularis means hair follicle. Pityriasis rosea. So, now you know pityriasis is scaly lesion. Rosea means pink. So, which are pink in color. So, these are some dermatological disease name, and these are Latin and Greek terms. So, in skin or dermatological jargon, these terms are used. And so, pityriasis, you know, tinea means insect, vulgaris means common, and lichenoid or lichen means leaf like. So, lichens are low level plants. So, its shape is like this plant. So, it is called lichenoid. Now, in this video, we are going to discuss these 30 plus definitions and its microscopic features, and this will help you to identify some specific as well as some general features related to particular diagnosis. So, before we start, let's see or let's revise what the normal skin looks like. So here this is the normal skin section. The outer layer is called stratum corneum, or it is scaly or horny layer. Second, if a section is from palm or sole, it is stratum lucidum, which is also acellular layer. Third layer, which is having blue or blue color granules or basophilic granules, so it is called granular layer. And beneath this is spinous layer, so it is stratus spinosum. It is having a processes, so it is called stratus spinosum. And last layer is stratum basalis, or it is called basal layer. And this basal layer is containing melanocytes which produce melanin pigment. And beneath the epidermis there is dermis, which is composed of papillary layer, and beneath is reticular layer. So this is normal skin pathology, histology. Now microscopically you have to remember stratum corneum is less than 1/3 of total thickness of epidermis. If it is beyond this or increased thickness is there, then some definition you have to use to describe that particular area. Now stratum granulosum, it is normally 3 layers. Stratum spinosum 5 to 10 layers, and stratum basale, which is columnar cells, single layer, and lucidum if skin biopsy is from palm and soles, then you can identify. Now let's start with the different definitions in dermatopathology. So first is hyperkeratosis. So you know keratosis means the corneum layer thickness. So corneum layer, if it is increased more than 1/3 of total thickness of epidermis, so it is called hyperkeratosis. So keratin layer or corneum layer, if it is thickened, then it is called hyperkeratosis. Orthohyperkeratosis, it is the term for hyperkeratosis with thickening of stratum corneum and normal granular layer. So here it may be either basket wave type or compact type. So basket wave type, it is in the disease called ichthyosis, such as ichthyosis vulgaris. Vulgaris means common. Compact type where lamellar ichthyosis and lichen simplex chronicus. So hyperkeratosis and orthohyperkeratosis where there is basket woven type of keratinous layer. So in this section you can identify this is stratum corneum, and this layer is thickened more than 1/3 of this total thickness of epidermis. So if you measure thickness of epidermis here, and if you measure the corneal layer or corneum layer, it is more than 1/3 of this epidermis. Now second is parakeratosis. So parakeratosis means it is where retention of nuclei are present in stratum corneum. So normally stratum corneum is devoid of nucleus. It is made up of keratin material only. So if you find nuclei in stratum corneum, it is called parakeratosis. It indicates delayed maturation process and altered process of keratinization. And in microscopy you find bluish nuclei within pink stratum corneum. So there are different types of parakeratosis in different skin diseases, like focal and scattered in dermatitis, cap-like in lichen nitidus, alternating with orthokeratosis and vertically arranged in viral warty lesions, alternating with orthokeratosis and it is horizontally, so it is in actinic keratosis, punctate in pityriasis lichenoides chronica with polymorphonuclear cells in psoriasis, vertical column coronoid lamella of porokeratosis, penetrating as in perforating disorders such as reactive perforating collagenoses and vertical and massive in epidermolytic hyperkeratosis. So, here in this section, what is parakeratosis? So, this is the corneal layer and here you can identify this bluish nuclei. So, presence of nuclei in keratinous layer, it is called parakeratosis. Here you can identify alternating, this is the parakeratosis and there is the collection of neutrophil. So, this is alternating with the neutrophil and parakeratosis. Mostly it is common in psoriasiform lesions. This is again another example of parakeratosis where you find wedge shape and columnar parakeratosis. So, it is vertical. So, it is called a vertical parakeratosis wedge shaped in the skin disease called cornoid lamella. Now, third definition is what is corpse grains and what is corpse rods. So, these are found in horny or corneum layer where it resembles parakeratosis, but here these cells are large and having clear nuclei with surrounding disc keratotic material and having perinuclear halo. So, presence in corneum layer, large cell with disc keratotic material. Now, disc keratotic means eosinophilic keratinous material in the cytoplasm and this is present in Darier's disease and Warty disc keratoma. Now, corpse rods. So, they are found again in horny layer as well as granular layer and upper part of the spinous layer. Now, these keratotic cells are recognized by large round basophilic pycnotic nuclei in the center with perinuclear halo and outermost basophilic cytoplasm. And these are seen in Darier's disease, Warty disc keratoma and focal acantholytic disc keratoma. So, here in this section, this is corneal layer, granules easily seen. So, this is granular layer, spinous layer and this is basalis layer. Now, corpse grain cells are here you can identify enlarged cells in the stratum corneum. They are having large nucleus and this is corpse rod. So, they are larger with perinuclear halo and bluish to pinkish cytoplasm. So, these are flattened and these are large and oval in shape. Now, acanthosis. Now, what is acanthosis? It is thickened stratum malpighi. Now, you know malpighi means two layers in combine like stratum spinosum and stratum basalis. If both layer are thickened, it is acanthosis which is seen with hyperkeratosis and it is a non-specific change in most chronic skin diseases. So, epidermal proliferative disorders like psoriasis, lichen simplex chronicus, laminar ichthyosis. It is also seen in benign skin tumors like seborrheic keratosis and actinic keratosis, as well as they are also seen in papillomatosis and pseudoepitheliomatous hyperplasia. So, acanthosis means thickened stratum malpighi. So, here you can identify the thickness of stratum spinosum along with stratum basalis. So, this is called stratum malpighi is increased. Normally 5 to 10 layers of the stratum spinosum are present, but here you can easily identify that this layer is having more than 10 to 15 layers of stratum spinosum. So, this is thickening of this layer called acanthosis. Now, papillomatosis. So, papillomatosis means papillary lesion like features. So, it is finger-like projection. So, here gross hyperplasia of epidermis with elongated dermal papilla pushing up the entire epidermis in the form of finger-like processes. Most common causes are verrucous skin lesions such as verrucous tuberculosis, subcutaneous fungal infection, pemphigus vegetans, pyoderma vegetans, and viral warty lesions. Tumors include seborrheic keratosis, hypertrophic form of actinic keratosis, some nevi, and nevus sebaceous. So, here you can identify these are the finger-like projection of epidermis. So, here in this cut section, you can easily identify these are the finger-like projection of epidermis. So, this is called papillomatosis. Now, pseudoepitheliomatous hyperplasia. So, it is a gross hypertrophy of epidermis resembling squamous cell carcinoma, and it is having irregular strands, cords and nest of squamoid cells extending into the dermis. Another term is hypergranulosis. So, hypergranulosis, it is increased thickness of granular layer to more than 5 layers. Normally, it is up to 3. So, 1 to 3 layers are normal. So, here in hypergranulosis, it is more than 5 layers, commonly seen in viral warts, lichen planus, epidermolytic hyperkeratosis and lichen simplex chronicus. Hypogranulosis, it is seen in all cases of parakeratosis and it is present along with the orthokeratosis in ichthyosis vulgaris, which is the specific diagnostic sign for this disease. So, this is now pseudoepitheliomatous hyperplasia. You can identify these are the irregular strands of epidermis, some cords and here nest of the squamoid cells which are extending into the dermis. So, it might mimic like squamous cell carcinoma, but here this is having intact basement membrane. So, this is called pseudoepitheliomatous hyperplasia. Now, hypergranulosis, here it is wedge-shaped hypergranulosis. So, increased number of this stratum granular layer where you can identify more than 5 layers. So, 1, 2, 3, 4, 5, 6, 7. So, these are the increased number of granular layers. So, it is called hypergranulosis. Now, epidermal atrophy, as the name suggests, decreased thickness of stratum malpighi to less than 5 layers. Normally, stratum malpighi or stratum cornea, stratum spinosum having 5 to 10 layers. So, here it is less than 5 layers. So, most common causes are steroid induced poikilodermas, atrophic lichen planus, lupus erythematosus, scleroderma, lupus vulgaris, lichen sclerosus at atrophicus, progeria, and some tumors. So here in this section you can identify there is thinning of epidermis and the stratum spinosum layer is having less than 5 layers. So this is atrophy. Now acantholysis. So here there is loss of cohesion or loosening of keratinocytes. So attachment between these keratinocytes, which is with the help of desmosomes. So there is damage to desmosomes and the cells are separated from each other. So singly scattered cells are present. It is due to loss of intercellular bridges. So it is called acantholytic cells. So these are singly scattered separated acantholytic cells and this is seen in Hailey-Hailey disease. So acantholysis in benign condition and there are neoplastic acantholysis. So what are the causes for benign condition? One is primary acantholysis. So primary it is without any cell lysis. So pemphigus, Hailey-Hailey disease, Darier's, vertidiskeratoma and transient encapsulatic diskeratosis. So these are some common examples. So these are the acantholytic cells. Here you can identify singly scattered cells. Now secondary to cell degeneration where subcorneal pustular dermatosis and some viral blisters like herpes simplex or zoster. Now neoplastic acantholysis where actinic keratosis and squamous cell carcinoma where you can find acantholysis. Another definition is important which is spongiosis. So spongiosis means sponge like. So where it is having fluid in between the keratinocytes. So it is accumulation of fluid in between keratinocytes which is called intercellular edema in the stratum malpighi. So here you can find microscopically space between two cells. So this is nothing but the edema in between the cells. Here because these intercellular bridges are stretched and there is fluid in between these cells. They appear separated and these intercellular connections stand out clearly and it is associated with exocytosis of cell. So what is exocytosis? We will learn in next definition. So here this is pemphigus vulgaris where you find spongiosis and this is eczematous dermatitis where also you can find this clear space in between these cells. So it is example of acute eczematous dermatitis. So what is exocytosis? Means exo means out. So migration of inflammatory cells into epidermis in the presence of spongiosis. Right. So cells are present at all level reaching even into the stratum corneum and it is the distinguishing feature from epidermotropism. So exocytosis is seen in mainly spongiotic disease. So cells are migrating in epidermis and these are mainly inflammatory cells. So cells you can identify everywhere in the whole epidermis. Now another terminology is epidermotropism. So what is epidermotropism? Here also you can identify cells in epidermis but they are mononuclear cells and there is absence of spongiosis. Exocytosis, spongiosis, no spongiosis and presence of cell, it is epidermotropism. These cells are present only in the lower one third of epidermis and do not reach beyond stratum spinosum. And classic examples are mycosis fungoides, adult T cell lymphoma, leukemia, and Langerhans cell histiocytosis. So, important note, exocytosis in inflammatory lesions, whereas epidermotropism is neoplastic. So, here you can identify, one is first of all spinosum layer show clear spaces, so it is spongiosis, and here you can easily identify clear space in high power view, so it is spongiotic lesion, and these are the inflammatory cells are present in between these cells in spinosum layer, even in the basal layer. So, this is called exocytosis with spongiosis, and these are the multilobated cells or neutrophilic infiltration. Now, this is example of epidermotropism. So, here you can identify, these are the dark blue cells which are mononuclear, and they are not only present in dermis, they are also present in epidermis. So, these are the dark blue mononuclear cells which is the hallmark of mycosis fungoides, and this is the example of epidermotropism. They are mainly seen in the basal layer and lower half of spinosum layer and without spongiosis. Now, microabscesses. So, micro means small, focal collection of cells either in epidermis or dermis. Abscess means collection of inflammatory cells. So, epidermal microabscesses, polymorphonuclear microabscesses, where you find neutrophils, important psoriasis, which is Munro type, and candida infection. If lymphocytes are present, so it is called lymphocytic microabscesses, which is present in Portier's microabscesses in mycosis fungoides, and dermal microabscesses, if you find, it is dermatitis herpetiformis, some form of vasculitis, and furuncles and cellulitis. So, these are microabscesses. So, here you can identify, these are the collection of inflammatory cells in the epidermis. So, this is Portier's microabscesses, where you find lymphocytic infiltration. And in Munro's microabscesses, you can find epidermal collection of neutrophilic infiltration here in the corneum layer. So, it is called Munro microabscesses, and it is a hallmark of psoriasis. Here it is dermal abscess. So, epidermis is normally free, but dermis show collection of inflammatory cells. So, this is dermatitis herpetiformis, and this is a section of skin. This is epidermis, dermis, and deep dermis show here a vessel which is having surrounding inflammatory cell collection. In high power view, you can identify cell wall is having infiltration with the inflammatory cell. So, this is vasculitis. Now, another terminology is ballooning degeneration. So, ballooning degeneration means the cells become swollen with fluid and it appears like balloon and having centrally placed nucleus. So, most common in herpes infection and chickenpox. Ballooning degeneration is seen in lower epidermis, and it is prominent in herpes simplex. Another type is reticular degeneration. When ballooning degeneration becomes more severe and cells rupture and margin fuse to form a reticular network, it is called reticular degeneration. It is mostly in herpes zoster and chickenpox, and reticular degeneration seen in upper dermis and prominent in herpes zoster. So lower dermis, herpes simplex, ballooning degeneration; upper dermis, reticular degeneration, it is mostly a herpes zoster and reticular degeneration. So here you can identify cells are swollen like balloon, some having centrally placed nuclei. So this is ballooning degeneration, and these are the multinucleated cells and some enlarged cells. So again balloon cells in herpes infection. Now here it is reticular. So severely damaged cells and uh, uh, swollen cells where they are ruptured and form this net-like pattern. So it is called reticular degeneration. Now what is necrotic keratinocytes and what is colloid bodies? So cells which undergo sudden death, they appear pink bodies with pycnotic nuclei in stratum malpighi. So necrotic keratinocytes having pink bodies with pycnotic nuclei, which is commonly seen in erythema multiforme, pityriasis lichenoid at variliform acuta or pleva, graft versus host disease, and photodermatitis. Now, these necrotic keratinocytes appear like colloid body, which is seen in apoptosis or programmed cell death. But these colloid bodies are mostly found in dermis, stratum basale, and they do not have central pycnotic nuclei. So, what is the difference between these two? Necrotic keratinocytes have a pycnotic nuclei, colloid body having absence of nuclei, only pink cell. So here you can identify these are the necrotic dark pink eosinophilic cytoplasm and very small nucleus. So it is necrotic keratinocytes, which is commonly seen in erythema multiforme. And what is colloid body? Which are apoptotic bodies or programmed cell death, where they are having only pink material without any nucleus. So this is also a civet body. They are also found in dermis and stratum basalis layer. So most commonly these civet bodies or colloid bodies are identified in lichen planus. Now coelocytes. So coelocytes are abnormal squamous epithelial cells which is having large clear halo around hyperchromatic nuclei, and it is mostly infected cells by human papilloma viral infection, and it is in the low grade squamous intraepithelial lesion LSIL. So these are dry resin like nucleus, irregular nuclear border, and clear halo around nucleus. It is called coelocytes. Now viral inclusions. They are abnormal structures within keratinocytes, and they look like having either distinctive shape or colors like glassy or grayish nuclei or some pink blue blobs, and most commonly we have to identify or diagnose it by PCR because some specific virus having specific viral inclusion. Most common are herpes simplex, varicella zoster virus or molluscum contagiosum. Now basal cell degeneration, most important to learn. It is also known as vacuolar degeneration or hydropic degeneration and liquefaction degeneration. It appears as a tiny vacuoles in the basal cells, leading ultimately to vacuolated appearance and extensive in lichen planus. So, whenever you find extensive basal cell vacuolation, we have to think of lichen planus, and there is which leads to a cleft formation due to this extensive basal cell dilation, and this cleft or this space is known as Max Joseph space. Focally present in discoid lupus erythematosus, in fixed drug reaction, lichen sclerosis heterotrophicus, another lichenoid reaction like secondary syphilis, some benign lichenoid keratosis, drug-induced lichenoid reaction, etc. Erythema multiforme, pleva, poikiloderma, graft versus host disease, and radiation dermatitis. So, most important, basal cell degeneration is seen in all interface dermatitis. So, interface dermatitis pattern we will learn in next topic in detail, but you have to remember whenever there is interface dermatitis, you will identify basal cell vacuolar degeneration. So, here this is basal layer, which is the last layer of epidermis, where you can find these vacuoles in this layer. So, this is called vacuolar or basal cell degeneration, and it is here seen in the skin slide of lupus erythematosus. So, this is called vacuolar degeneration of basal layer, right? Now, pigment incontinence. So, it is the dropping of pigment into upper dermis where it may be found either free or inside macrophages called melanophages. So, it should be distinguished from hemosiderin by the use of special stain called Maison Fontana for melanin and Pearl stain for hemosiderin. It is seen in all conditions with basal degenerations. Also seen in chronic ichthyal lesions, in incontinenta pigmenti and post-inflammatory pigmentation. So here you can identify, first of all, this is corneal layer, granular layer, spinous layer, and this basal layer having increased amount of pigmentation, and these pigmentations are also identified in the dermis layer. So, here this is melanin brown black pigmentation present in the dermis. So, it is called pigment incontinence. So, dropping of pigment from basal layer to dermis is called pigment incontinence, and this is called vacuolar interface. Some of the area show this is basal vacuolization. Now, interface dermatitis. So, interface means at the level of, at the junction of epidermis and dermis. So, where inflammatory pattern which is seen at the or dermoepidermal junction, which is characterized by these three things. One is basal cell vacuolization, we have already seen, presence of apoptotic keratinocytes or colloidal civet bodies, and obscuring of dermoepidermal junction by inflammatory cells. So, this is called interface dermatitis. There are two types. One is interface dermatitis of vacuolar type, another is interface dermatitis of lichenoid type. Now, vacuolar type means you will find vacuoles at the level of basal layer and junction. and it is seen in erythema multiforme, pityriasis lichenoids at variable from active or pleva, and this interface dermatitis of lichenoid type which is seen in lichen planus and other lichenoid reaction. So this is the example of vacuolar type where you can find this vacuolar degeneration of basal layer and some of the dermis, upper part of the dermis show mononuclear sparse infiltration. Now another type of interface dermatitis is lichenoid type. So lichen planus is classic example where interface dermatitis, as we have discussed, at the junction of epidermis and dermis there is a band-like infiltration of lymphocytes. So this is called interface dermatitis of lichenoid type. So lichen planus having this pattern, and what are the other features which you will identify under microscope are, one is wedge-shaped hypergranulosis. So this is called wedge-shaped hypergranulosis. Now what is wedge-shaped? Wedge-shaped means this V-shaped area shows hypergranulosis. So number of granular layer are increased. In between these two wedge-shaped area, there is normal granular layer. So it is called wedge-shaped hypergranulosis. Second is compact orthokeratosis. So here you can identify increased amount of thickness of keratinous layer and irregular rete ridges. So these are the rete ridges, right? So this is irregular in nature and this is lichenoid lymphocytic infiltration at the junction and in the papillary dermis. So this is how you can identify lichen planus features under microscope. Now disc keratosis. So disc keratosis, it is abnormal keratinization below stratum corneum. So in spinosum or basal layer you can identify keratinized squamous cells. Normally stratum corneum is composed of keratinous material, and here eosinophilic cytoplasm and pycnotic nuclei is identified. It is seen in actinic keratosis, squamous cell carcinoma and Darier's disease. And these are the markers of atypia, precancerous or malignant potential. Now, as it indicates abnormal and premature keratinization of individual cells, it shows pinkish color with small dark blue nucleus. One is acantholytic disc keratosis, where you identify mainly in Hailey-Hailey disease and Darier's disease. Transient acantholytic disc keratosis is seen in corpse rounds and grains. Second is neoplastic disc keratosis, like in Bowen's disease, actinic keratosis, and squamous cell carcinoma. And third is geniodermatosis, which is incontinentia pigment. So hyperkeratosis means thickened keratin, which is protective response to any injury, while disc keratosis means abnormal keratinization, which is indicative of precancerous lesion. So here you can identify this acantholytic keratinocytes which are present here, and this will turn into a dyskeratotic cell. So dyskeratotic means pycnotic nucleus, right, and eosinophilic cytoplasm, deep eosinophilic. So you can compare the cytoplasm of these acantholytic cells and this is dyskeratotic cells. So Here it is basophilic, eosinophilic, and here it is deep eosinophilic, and this is called corpse bronze. And if it is flattened, then it is called grains. So yellow arrow shows corpse flattened grains. These are round corpse ronds. Ronds means round, and here these are the acantholytic cells. Now neoplastic disc keratosis. So here in this section you can identify pink eosinophilic cytoplasm of cells with nuclear uh, enlargement. So this is neoplastic disc keratosis in Bowen's disease. So nuclear features help in diagnosis of neoplastic disc keratosis. Now what is keratin pearl or horn pearl? So here it denotes presence of concentric layer of squamous cells with keratinization, and this squamous ED is concentric wall of keratinocytes with incomplete keratinization towards the center. Hence the wall which is bluish at the periphery and having progressive pinkish toward this center. So most common example of keratin pearl, one is squamous cell carcinoma, one is irritated seborrheic keratosis, verruca vulgaris, keratoacanthoma, pseudoepitheliomatous hyperplasia, and proliferating trichilemal cyst. So here this is how you differentiate what is keratin pearl and what is horn pseudocyst. So horn pseudocyst means it is a cyst-like space but not actually cyst, which contains acellular keratinous material. So cystic space containing keratinous material, it is called horn pseudocyst. And here it is keratin pearl where you can identify nucleus and pinkish in center and bluish in surrounding area. So horn cyst is basically present in the stratum malpighi with pink keratinous material, and normal keratinocytes are surrounding this cyst is identified. This is result of endokeratinization, that is keratinization occurring stratum malpighi instead of stratum corneum. Normally keratin is present in corneal layer, but if you find this keratinous material in the malpighi, it is called endokeratinization. And it is common in seborrheic keratosis, basal cell carcinoma, trichoepithelioma, and sweat gland carcinoma. Now follicular plugging. Now follicular means related to hair follicle. So it is characterized by plugs of compact keratin in hair follicle, commonly in discoid lupus erythematosus, follicular lichen planus, where you find one flask shaped plug. Here it is cone shaped plug in discoid lupus. Lichen sclerosis atropicus, acne vulgaris, keratosis pilaris, pityriasis rubra pilaris, follicular seborrheic dermatitis. So this is follicular plugging. So pigment incontinence, you can identify dark pigment in the dermis. There is damage to basement membrane, and this is called follicular plugging, where you can find keratinous material inside the hair follicle area. Now grain zone. So it is the clear zone. So here you can identify, see, this is corneal, granular layer, spinous layer, basal layer, and this is dermis. Now in between this basal layer and this dermis you can find clear zone. So grains means boundary. So here you can identify a boundary between epidermis and dermis. So it is called grain zone, most commonly in lepromatous leprosy, where there is thinned epidermis and presence of grain zones and plenty of histiocytes in the dermis. So one is lepromatous leprosy, intradermal nevi, lymphocytoma cutis, granuloma faciale, then acrodermatitis chronica atrophicans, pseudo lymphoma cutis and colloid milium. So these are the example where you find grain zone. Now cleft. So cleft means space inside the epidermis or at the junction. So cleft in epidermis, which is empty space mostly in bullous lesion like pemphigus and Hailey-Hailey disease, Darier's and Varti diskeratoma. Now junction, at the junction, lichen planus, which is Max Joseph space and Spitz nevi, and cleft in dermis. So it is in squamous cell carcinoma, basal cell carcinoma, where it is retraction artifact, cholesterol cleft in fat necrosis, gout and amyloidosis. So here you can identify this is epidermis, and in the epidermis you can identify this cleft. So it is called intraepidermal cleft, where because of cleft the cells are separated, which is called acantholysis. So acantholysis, cells are separated and it gives an appearance of dilapidated bricks. So here you can identify these are the broken wall where these bricks are irregularly placed. So you can compare this area as a dilapidated bricks wall appearance in the Hailey-Hailey disease. So you can imagine these are the bricks, they are not properly arranged and they are having derangement in the appearance. So this is Hailey-Hailey disease where you can identify cleft-like spaces. Now extravasation of RBCs. So into epidermis, if you find RBCs present in between the cells, not in capillaries. Generally, RBCs are present inside the capillaries. But if you find RBCs present in between the epidermis, it is called extravasation of RBC. Mostly in epidermis, it is pityriasis or pleva, lymphomatoid papulosis. And if you find this is RBCs are outside the capillaries and in the papillary dermis, so it is called pityriasis rosea, seen in pityriasis rosea, stasis dermatitis, all form of vasculitis, lymphomatoid papulosis and Kaposi's sarcoma. Now dermal edema. So dermal edema, where here you can identify this epidermis and dermis show clear space due to fluid and it is pale in appearance and due to absorption of water, and it is because of fixation where water will give appearance of clear area. So it is most commonly seen in erythema multiforme, dermatitis, pleva, toxic epidermal necrolysis, acute lupus erythematosus, blistering lesions like herpes and some dermatitis herpetiformis, vasculitis. This section is of sweet syndrome where you find extensive amount of dermal edema, some insect bite reaction and lichen sclerosis at atrophicus. Vasculitis. So there are criteria to stamp as vasculitis. One is damage. So damage to vessel wall leading to hyalinization of vessel wall. Second, infiltration of vessel wall by inflammatory cells, which is with the polymorph. Deposition of fibrinoid or PAS positive material which is composed of fibrin or immunoglobulins and complements and in and around the vessels. Fourth, extravasation of RBCs, and fifth, there is presence of nuclear dust. So all these criteria will help us to diagnose vasculitis. So it should be distinguished from perivasculitis where the vessel wall is normal but only accumulation of inflammatory cells around blood vessels without damage to vessel wall. So actually when vessel wall is damaged, it is called vasculitis, and most common is in the polyarteritis nodosa. So this is the section of skin, epidermis, dermis and deep dermis show medium sized vessel. And this vessel in high power view you can identify vessel lumen is very much narrowed and neutrophils are present in the wall of the artery, and there is myelinization or deposition in the wall. So this is vasculitis. Now, what are the different inflammatory cells you identify in skin biopsy, and according to the presence of that inflammatory cells, we can have some diagnosis like polymorphs. So if you find epidermal microabscesses or pustules where you find neutrophils. So these are psoriasis, impetigo, scabies, some candidiasis and dermatophytosis, transit neonatal pustular melanosis, pyoderma vegetans, fungal infection, some necrolytic migratory erythroma, pustular vasculitis. And if you find dermal polymorphonuclear infiltrate, these are leukocytoclastic vasculitis, Sweet syndrome and dermatitis herpetiformis. Eosinophils. So eosinophils if you find in epidermis, that is pemphigus, bullous pemphigoid, some insect bite, some fungal dermatophyte reaction infection, incontinentia pigmenti and eosinophilic pustular folliculitis. If in dermis, it is atopic dermatitis, erythroderma, parasitic infection like scabies or larva, allergic lesions, eosinophilic fasciitis, bullous pemphigoid, herpes gestationis, granuloma faciale, annulare, mycosis fungoid, and some urticaria and urticaria pigmentosa. Now, plasma cells, mostly seen in syphilis, rhinoscleroma, rhinosporiosis, leishmaniasis, and some fungal infections. Mucosal diseases like plasma cell cheilitis, balanitis, oral lichen planus, chronic folliculitis and folliculitis decalvans, necrobiosis lipoidica, granuloma faciale, some lupus erythematosus and scleroderma, and some tumors like actinic keratosis, squamous cell carcinoma, and multiple myeloma. Now, here some of the diseases show lymphocytes, but that doesn't mean that it is chronic, because acute disease often have infiltrate of lymphocytes, right? And macrophages are mostly seen in chronic disease. So lepromatous leprosy, here this section show plenty of foamy cells. So these are the foamy macrophages present in abundance in the lepromatous leprosy. Some of the leishmaniasis, fungal infections and xanthomas and xanthogranuloma where you find macrophages. So in skin lesion, acute disease often have infiltrate of lymphocytes, that you have to remember. Now giant cells. As there are different types of giant cells like epidermal giant cells mostly in herpes simplex, herpes zoster, Bowen's disease, melanocytic giant cells like in melanoma or nevi, tumor giant cells like fibrous tumor containing giant cells are dermatofibroma, MFH, giant cell tumor of tendons, lymphoma where you find Reed-Sternberg cells, fat cells like floret giant cells in pleomorphic lipoma. Foreign body type of giant cells where many macrophages in with the granulomas or suppurative granulomas. Langhans type of giant cells where mostly in tuberculoid granulomas. Endothelial giant cell in cytomegalovirus infection and Teuton giant cell which is having central foamy cytoplasm due to lipid and surrounded by floret or wreath-shaped arrangement of nuclei. And it is found in xanthomas and xanthogranuloma. So, we have discussed most important definitions or terminology, and we have seen how you identify under microscope. So now it's a turn to apply it when you do microscopy. So remember, first you remember definitions, correlate with microscopy, now make a pattern, and finally the diagnosis. So we have discussed definitions and microscopy. In next topic, we are going to discuss approach to skin biopsy according to reaction pattern, and we will recognize inflammatory lesions. So I hope now you understand uh, how to describe each specific detail in skin biopsy properly with the help of these definitions. And in next topic we will learn approach. So if you haven't yet subscribed this channel, please subscribe and also like, share and comment so that I can make topic accordingly. And thank you for listening. See you in next topic.